Hello, my name is Dr. Mark Frizzell. I'm the Associate Medical Director for Oncology at KRAS Diagnostics. And it is my distinct pleasure to talk to you today about innovations within precision oncology, specifically about the evolution of a new biomarker and a case study, KRAS G12C. This content of this presentation is not part of the educational sessions of this conference. CME credit does not apply, and I am a full-time employee of KRAS Diagnostics. During this session, we'll review the evolving non-small cell lung cancer biomarker landscape, raise awareness about KRAS G12C as an actionable molecular target for non-small cell lung cancer, and discuss the available testing methodology and clinical guideline recommendations for biomarker testing within non-small cell lung cancer. As we know, lung cancer is a very prevalent disease. Nearly 230,000 patients will be diagnosed with that in the coming year. 136,000, almost 136,000, will die from that disease. Non-small cell lung cancer accounts for about 85% of all lung cancer diagnoses, and 60% of those patients are diagnosed at an already advanced stage. Treatment outcomes and overall survivals have been generally poor, with a 5-year survival of about 6%. Immunotherapy has improved overall survival in a subset of patients that respond to that therapy. Despite biomarkers serving as the foundational cornerstone for non-small cell lung cancer therapy, molecular testing rates are still suboptimal. Non-small cell lung cancer is a heterogeneous disease. There are many actionable biomarkers, the tried and true EGFR and ALK rearrangements to the new NTRK fusions and PD-L1 expression and tumor mutational burden analyses, to now KRAS G12C having become a new actionable target. Molecular characterization of non-small cell lung cancer through biomarker testing is essential to inform the patient and to inform patient management. So what is the KRAS gene and how do those mutations drive tumorigenesis? Well, KRAS is a regulator of cellular proliferation and differentiation. It belongs to the RAS family of genes, of which there are 3 isoforms. KRAS is the most prevalent and common found within lung cancer. It encodes for KRAS proteins, which are small GTPases that regulate signaling pathways responsible for cellular proliferation and differentiation. KRAS proteins cycle between bound or active states and unbound or GDB bound inactive states. In normal cells, KRAS serves as the on and off switch for cellular proliferation and downstream signaling pathways, which is illustrated on the right-hand side of the slide. However, in the mutated and altered state, KRAS tends to favor the active form, particularly KRAS G12C, thereby supporting tumorigenesis and sending signals downstream to promote cellular proliferation and differentiation. So why is KRAS so important, and how common are KRAS mutations? And how is KRAS a target? Well, KRAS G12C is an actionable molecular target. It is the most common driver mutation in lung adenocarcinoma. And G12C specifically accounts for nearly half of all KRAS mutations in non-small cell lung cancer. 13%, or 1 in 8, of all patients with non-small cell lung cancer have the KRAS G12C mutation, which is comparable to the prevalence of EGFR mutations. Despite nearly 4 decades of scientific efforts, targeting KRAS has been one of cancer's toughest challenges. And there are really 3 reasons for that. KRAS proteins really lack the surface pockets, which make tight binding of small molecules quite difficult. They have competitive inhibition. It tends to be challenging due to the high affinity of binding of GTP to KRAS. And non-selective binding to wild-type KRAS can inhibit wild-type KRAS and adversely affect normal signaling pathways. However, through innovation and many years of research, KRAS structure reveals unique features which can be used to have it be a target. So cytosine 12 may allow for potential irreversible covalent bonding. P12 pocket is present in the inactive GDV-bound KRAS G12C and provides a potential binding site for small molecules. And the H95 residue may provide a site to stabilize drug and protein interactions. Inhibition of KRAS G12C represents an important therapeutic approach in non-small cell lung cancer. Targeted inhibitors could selectively lock the G12C mutant protein in the inactive state, thereby blocking the oncogenic signaling without affecting the wild type states. So now that we've examined KRAS and specifically KRAS G12C, how do we find it? How is it determined? Well, there are multiple ways of methodologies and approaches to testing for KRAS G12C. Both tissue and liquid biopsies are appropriate, as are single and multi-gene platforms. And reporting guidelines have been designed to help with interpretation and guidance on therapy selection. Tissue biopsies remain the gold standard. However, liquid biopsy has become much more commonly and frequently used, particularly in instances when insufficient tissue is available or the patient's performance status is of crucial importance. Liquid biopsy in non-small cell lung cancer tends to be reserved for those patients that are particularly ill and need a rapid result, and in which the tissue specimen was insufficient. If we look across all of the guidelines that are recommended for therapy selection and testing in non-small cell lung cancer, CAP, ISLEC, AMP, ASCO, and NCCN all unanimously recommend KRAS testing, whether it be in a single gene setting or an expanded panel setting. In conclusion, we know that non-small cell lung cancer can be a very heterogeneous disease, and there are multiple molecular alterations that are important and will help guide and inform treatment options. KRAS G12C is one of the important prevalent driver mutations in non-small cell lung cancer, occurring in nearly 1 in 8 patients, with a very comparable prevalence to EGFR. Inhibitors of KRAS G12C block the oncogenic signaling and are an important therapeutic approach in non-small cell lung cancer. Guidelines recommend testing for KRAS mutations along with other biomarkers. And KRAS G12C can be reliably detected by both PCR and NGS in both tissue and plasma alike. Thank you for your attention today. I hope you found this very educational.